Welcome to Channel 17, the Town of Colonie Government Channel.
Hello and welcome to Focus on Health. I'm your host, Peggy Mello. Today's guests are Sabrina Mosseau and Barbara McHale with the Cancer Treatment Center at Samaritan Hospital. Thanks for coming, ladies.
Thank you, Peggy.
Sabrina, let's start with you. What do you do for Samaritan?
Peggy, I'm the Administrative Director of Medical Oncology at the Cancer Treatment Center at Samaritan Hospital and the Director of the Women's Health Center as well.
Oh boy. And Barbara?
I'm the patient navigator at Samaritan Hospital. I work with all the patients that are diagnosed with breast, colorectal, lung, head and neck cancer at the center.
Okay. Sabrina, can you tell me the history and background of Northeast Health?
Absolutely. Northeast Health is an organization that consists of 3 acute care hospitals, Albany Memorial Hospital, Samaritan Hospital, and also Sunnyview Rehabilitation Hospital.
Okay.
It's really a full-service continuum. We have primary care offices, we have outpatient imaging centers, inpatient imaging centers, surgeons, radiologists, kind of the complete comprehensive services that anybody would actually need access to.
Mm-hmm. And tell me, what services are provided at the Samaritan Cancer Treatment Center?
Cancer Treatment Center is a very comprehensive cancer center. It has a field of medical oncology, which most people typically think of when we think of chemotherapy drugs or biotherapy drugs.
Mm-hmm.
And besides the cancer portion of medical oncology, there's also the hematology portion, blood disorders, blood cancers, anything like that. The other secondary piece of the Cancer Treatment Center is radiation oncology. Again, a huge modality for some of our cancers, particularly for prostate and for breast cancer. Radiation oncology plays a big role. The most up-to-date imaging machines that we can possibly have in this area, doing IGRT, IMRT, and high-dose radiation. And the other piece that really is more important is the integrated wellness component and the patient navigation component, which we're here to talk about today.
Yes, and that's my next question is, can you please describe the concept of patient navigation?
Yes. Patient navigation is development that actually happened in Harlem, New York, with a physician, a surgeon, Dr. Harold Freeman. At that time, being a surgeon in Harlem, he actually realized that African American women were more likely to be diagnosed at a later stage of breast cancer. So when he looked at everyone, and there should be people who fall in stage 1, stage 2, stage 3, stage 4, he realized that statistically there was something wrong where he worked because more African American women were diagnosed at stage 3 and 4.
Much later in the process.
Yeah, and he looked back into that and said, obviously where the cracks were was having access to not only the screening, mammography screening, but getting to screening. Once you were screened and they said there was a problem, how did you get back for a diagnostic mammogram, and all the barriers that these women were experiencing that they didn't come in until a late stage of being diagnosed.
Okay, so does that help someone actually follow up with following annual mammogram schedules or?
Many, and one of the ways that we did start the navigation program is we actually started it based upon breast cancer, for a number of reasons, one of them being women are the demanders of healthcare, they are the providers of healthcare, the decision makers in healthcare, really in our region also, and that breast cancer is so near and dear to folks. People recognize the ribbon, they do the walks, they understand it. And the first thing we did is we went into our Women's Health Center and said, are people coming back for their screening mammograms? And how do we help that? We decided that we would do postcard reminders to individuals, that we would reach out and work with our primary care physicians and our OBGYNs and make it easy for them. We developed our own scripts where the doc could just check boxes, sign the script, hand it to the patient. The map was on the back. The follow-up with a woman, typically women would leave, they would wait for a call for their doctor to say what their next step is. We don't let women leave after a diagnostic mammogram until we can have a conversation with them about what the next step is. Step 1 is you're clear, step 2 is you need to go back to your primary care provider or your surgeon, and we call those folks. We don't let the burden of responsibility stay with the patient because we know they're scared. we call them.
So they have to wait until the film has been read.
Right, and for a diagnostic mammogram, we don't have any more film. We actually utilize digital mammography. The radiologist reads a diagnostic mammogram that same day and has a conversation with that patient the same day, so you don't leave wondering whether or not your diagnostic mammogram, when you knew there might be a problem, whether there's a problem or not.
Well, you know what I wish? I wish it was a law that the doctor's offices could remind you
Right.
when your annual physical and your annual GYN check and your annual mammogram were due.
Right.
Because I can never remember
Yeah.
when I have to go for those. Okay. So, Barbara, you have patient success stories. What are some of your patient success stories?
Well, when a patient's diagnosed with cancer, they're so overwhelmed that they can't even think and prioritize what needs to be done. So if I meet with them and we know that they have to get into a surgeon or to see several different specialists, I try and coordinate their care with them. They decide who they want to see. We can schedule everything, get it where it moves quickly. So versus waiting 2 to 3 weeks to get into a surgeon, usually I can get them in within 2 to 3 days, depending on the surgeons. The offices all work very well together. We get all the doctors' notes over to them so they know exactly what needs to be done.
And you know the staff at the other offices, so you can
It does
just call
help.
and say, "Hi, can I speak with Betty?" And then you're talking to the right person.
Well, if they know that you follow up and everything is done appropriately and that you're only looking out for the patient's best interest, it just helps sometimes to coordinate the care. And coordinated care does lead to better outcomes. So that's the bottom line. And once you can get a patient into the surgeon, we've had patients go see the surgeon and he said, well, you know, I want you to see a medical oncologist, radiation oncologist. We were able to get them seen by both of those physicians within 2 days. So by the time they returned to see the surgeon 5 days later, he was surprised because she'd already been seen by the docs or he had their recommendations. So she could go in with a better knowledge base and then could proceed with the surgery the following. I think she had it done 2 days later at her choice.
So, she may not have been emotionally ready, but
No, at her
she got
choice.
the surgery.
At her choice. You know,
Yeah.
we don't push them. Some people take a long time. I had one lady who in July, I still remember this, July 27th, several years ago, decided she was not going to have the further workup, was not going to have a biopsy when they were positive. It was a positive pathology by the mammograms, everything else. She put her head in the sand, just didn't want to do anything. And her doctor, her primary care, talked her into going to see a medical oncologist without the further workup being done, hoping some knowledge would help her. And when she came in, she was adamant she was not going to do a biopsy. We did get a biopsy done, and it was positive, but she did not want to follow up on treatment. That was the end of July. I called her and talked with her every 2 weeks until finally in November she called me back. I would leave messages on her machine
messages.
just saying, I'm thinking about you, just wanting to know that I'm still here if you need to talk, because she hadn't done anything, no surgeries or anything other than the biopsy. By November, she called one day and left me a voice message and said, hi, I bet you're surprised to hear from me. I'm ready to talk now. And so then she wanted more information, came in. I gave her a book. I kind of wasn't sure if she would read it. She read it from front cover to the back and called up and said, okay, I need to proceed with surgery and what kind of chemo. And I was shocked. So the outcome was the lady had the surgery done. By the time all this transpired, it was December 23rd, since July. She had advanced by that time, but do you know she's finished, she had the surgery, she had treatment, and she's just being monitored now, and she's doing great. But it took that long. If no one had been there to follow up, she wouldn't probably be alive now, because she really would not have pursued it.
So the concept of navigation is it's not just about getting a doctor's appointment.
No.
It's about all of the records being sent, all of the diagnostic images, everything, so that they can be evaluated.
It's coordinating care if they want second opinions, and the doctors are also recommending second opinions. we try and we do get everything together and get it down to wherever they're going for their second opinion, kind of facilitate everything, and then they can come back after, and most of the time the second opinions basically agree with the treatment plan because it's national standards. But it makes the patient feel better. So we help with everything. If they need clinical trials, they want to look at that, we'll send them to the centers that are doing the specific trial that they're interested in, so that they never feel that there was something left and that they didn't get every opportunity. It's pretty vast. I look at whether they need help with finances. A lot of times when they're going through treatment, they can't work. Then you deal with issues with maybe not making your mortgage payments or not having your rent. And there's a lot of support systems that are available for these people. So we kind of help. I work with Albany Law. They have a health clinic. They have lawyers that are available to assist these patients. They are working on different, they have a class action suit for foreclosures on patients' mortgages with who have been diagnosed with cancer. So you have people, and yes, they're just available to help. If you do have insurance, but maybe it's going to run out because you can't work, we try and assist and get whatever needs to be done. We have them work with Cardone Healthcare at our hospital, and we get them through for Medicaid, Medicare. There's just so many different avenues, and it's mind-boggling, but they can get assistance through the hospital.
And I'm imagining that just the process of applications is overwhelming.
It is.
And if somebody's older and they have to do things online, they may not even have ever used the internet before in their lives.
No.
They just don't know.
And that's where the person-to-person touch helps. We have a really good resource through Northeast right now, and they work closely with us. If the patients also, some of the drugs are very, very expensive, and some of the insurances have very high copays or deductibles right now. So I try and assist. We either sometimes can get assistance through the drug companies themselves if someone does not have the ability to get the drugs. And we've had patients that have been able to be receiving the medication with the drug company providing it because there was such a documented need. You have to go through a lot of paperwork, and patients would not know how to do this.
Wow.
So I think, and especially with the oral chemotherapy, the copays are so high, and the patients just, I could not afford $800 to $2,000 a month to pay out of pocket to get a drug that I desperately needed.
Right.
And that's where we work with different chronic disease fund. They've helped us with a lot of the patients. And then the patients just have a normal copay to assist them.
Well, they must reach their donut hole pretty quick, huh?
It's not even a donut with these orals. The drugs are just very expensive, and their biotherapy is specially targeted, and it's what their treatment, the best treatment for them. So I just keep plugging along. We find different avenues. We find different resources. You hit your head against the wall a lot of times, but at least the clients, they don't feel like they're just left alone. They're so overwhelmed with just the diagnosis. To try and deal with everything else would be just monumental. And some of them would not seek treatment then. I truly believe they'd just stop because they don't want to bankrupt their families.
And I'm imagining if you've gone through how many of the paperworks with how many different people that you probably know it pretty well and you could get through it a lot faster.
No, I know who to call, who to contact. Let's put it that way. I mean, I've attended different seminars, but you do know someone who specializes in everything, and I will ask for help. I will call Albany Law, and I will ask specifically. I know several of the people there and say, I've got this, this, this. How do we proceed? What do you recommend? I go to our Cardone healthcare person, and she is the specialist. I can hand off once I know exactly who's the best avenue to go and what resources. I can guide patients to different resources. We give them a ton of information about the resources that are available in the community that a lot of people don't know about.
But you just hope they don't have to call a 1-800 number and press this for this and this for this.
Well,
people are probably
there is actually,
But it's great.
there is a resource number. It's 211 that I use now, because I used to just go and tick off all these things. If I have the patients call the 211, I give them the information. It is like a clearinghouse. They ask your zip code right off.
The United Way, right?
Yes.
Right, funded through
Okay.
United Way.
And it's wonderful because it brings up, once they get your zip code, and you can tell them your story. And I'll tell the patient, sometimes they've even been there when the patients have called, and they can center what their needs are, if they need help with rent, if they have eviction, possibilities, if they need help with Medicaid, Medicare. They can.
Niagara Mohawk Bill.
Yes,
is another
Niagara,
one that
the
works really
advocate.
closely with them.
Yes.
Oh, boy.
There are wonderful services around, and that is a great one for anyone in this area. And it doesn't have to be even if you're with cancer. It's anyone with issues.
Okay.
Yeah.
How's that?
Interesting. So, Sabrina, can you give me a little bit more detail about the Patient Navigation Center? The advancements in your, what kind of diagnostic items do you have there?
When we talk about patient navigation, so the question has struggled for a while, actually, ever since Harold Freeman did it in 1990, was to say, what's the outcome? I mean, what do you actually accomplish at the end of the day by putting a human being in
Did
place
they ever
as a
follow it up?
navigator? Right. So what's really interesting for us is when we initiated the patient navigation program, we decided that we were going to put quality indicators in place. And one of those quality indicators was national data shows us that it typically takes somebody 19 business days to get from a clinical diagnosis to the first intervention, whether that first intervention is
19
surgery
business days.
or radiation or chemotherapy or whatever that happens to be. We are actually at 13 business days right now. So we really beat the pants off the national standard almost by a full business week, which is huge because we're beating national centers, national cancer centers of excellence that most people would recognize. Their business days to an actual treatment plan are usually longer than ours. So that was one of our hurrah, very big hurrah moments. Another very, very big hurrah moment was that ability to actually have a radiologist, the radiologist who had done your breast biopsy, actually sit down with you in person to tell you the results of your breast biopsy with the patient navigator sitting by their side. There is so much research out there that people say receiving a phone call at 2 o'clock on a Friday telling me, oh, we're very, very sorry, but your biopsy came back positive for breast cancer is not the way we should be delivering medicine. We've gone from this world of hiding things, not including patients in care, to all of a sudden saying, we're not going to hide things, but we're going to do, insensitive truth telling, and we don't want to be that organization. We don't want to be the insensitive folks. So we schedule patients automatically after their biopsy to come back in. If they're negative, and that's fantastic. If they're positive, they have the human being who did their biopsy telling them that and saying, I'm very sorry, this is not what we wanted. And they have Barb sitting there to then say, what do you need now? What do you need? And you know what? People may not know.
May not know.
But it's
Nope.
you may not know, and that's okay. Who can we help call for you? Call me tomorrow, or I'll call you. What works for you? And again, it's that ability to have people whose lives are being affected control their own choices, but knowing that they can make a phone call and they can get a result. Or they can say, hey, this is what I heard, can you put me into the right direction? That's astronomical, and we've gotten, these things are great when they're quality, they're fantastic when we can be published. We're nationally presenting in September, the National Nurse Navigator Conference. We're being published in the Journal of Oncology, Navigation and Survivorship in September, so there's some huge stuff we've done. But then the question becomes, that's great, but how do people feel about it? And so we do patient satisfaction surveys, and to say, is there value to this program? Do you, as the person who's consuming the program, see value in it? And it's statistically a significant value-added component to cancer care. It's too complex. There's too much stuff going on, and the gamut of patients that say to Barb, oh, I just want to be able to check in with you once every 3 months, as compared to the patients who say, I need you. I heard 3 different things. I'm going to repeat them to you. Help
Everyone's
me
always going to
decide.
say, oh, I heard that my cousin this happened to her.
Right.
And
if you
this
have
is what happened.
surgery, the cancer will spread.
Right.
That's a big thing that patients say. And they
They'll miss.
Barbara, I'm imagining your phone's ringing off the hook right now.
It's good because the patients, even if I've worked with them and we've gone through various things, if an issue comes up and they're not really sure, do I call the medical oncologist? Do I call the radiation? Do I call my primary? I may get a call from them because they know they can ask. And, you know, if I'm not there, if I'm seeing a patient, I call them back when I get the message. But usually I can direct which is the best avenue for them to go. And it really does help. You know, and the patients have the sense there's always someone that can kind of like triage them and which is the best way to go.
And your needs change. They
Yeah.
change from that acute stage of a cancer diagnosis to the, okay, now I'm in treatment and here is a plan, to the acute stage is over, this active stage of treatment is over, and now I'm into survivorship. What does that mean? That's huge territory.
Yeah.
We have 13 million survivors.
It's not just about a walk.
Have to do this.
It's about more than that.
And how do we accommodate that, and also taking some of that fear away and that anxiety of, we have to be very sensitive that people don't want to talk about, issues like sex and money. Those are big issues that, we don't talk about in daily conversation. But those are issues that come to the forefront of the patients that we're caring for, and we see individuals will tend to confide into Barb about money issues that they may not necessarily tell the person who's like, hi, good morning, oh, your copay is $20, They'll tell Barb issues, the medication is just, really ruining my relationship, and I'm not quite sure if it's a medication, if it's me, is it anxiety, is it stress, but they're not, they may not tell the physician that, because it's the pain that's high on top of their list, and it's the chemo drug, not the sexuality piece about it. And so it's really, really nice to see that there's a confidant that people also have in a relationship, and they know that Barb is then going to take that and follow that up with the next step, which means that Barb is surrounded by a fantastic team. She's surrounded by oncology nurses that are responsive and responsible. If Barb brings the issue to them, they act on it. By medical oncologists and radiation oncologists that say, the patient didn't tell us this, and we're so glad that now we know, because now we can adjust our plan and we can initiate the conversation. And it's that whole, medicine versus people, that people are afraid still to initiate conversations with their healthcare providers, especially things that make you nervous and jumpy.
Well, I'm the consumer health librarian here at the Colonie Library, and one of the things that I tell people is, if you don't feel that you can speak with your healthcare provider comfortably, and if you think that they're ignoring your questions or your concerns, there's always somebody else that you can go to.
And that's what we tell them too. You have to be comfortable with your caregivers and who's going to be overseeing your care. The patients will call regardless, and sometimes the questions aren't life-threatening, but sometimes because I'm a medical oncology nurse, I am always thinking and listening. And I just recently had a patient who called and said, Barb, I'm all done with treatment in this. It's been a couple months, but I have some questions. I don't know what to do. Who do I call? What do I do? She was having some problems writing. She noticed her writing was off. I asked her, do you have headaches? Do you have blurred vision? Are you dizzy? Do you have this? Do you have that? Because she had a diagnosis of lung cancer. My primary concern is that she's going to have a brain metastasis.
Oh, boy.
After talking with her and really discerning, I said, I'll call you back. Let me run it by the oncologist. So I went upstairs and I talked with the oncologist, and we'd all decided, the number one thing, they wanted to do a brain MRI, which they did, and they did find out she had lesion, and she just had to have brain surgery and now is having radiation start. But if she hadn't called anyone, it would have progressed and she might have lost more function.
Well, that's significant. If somebody can't
Exactly.
write, that's really...
But it was
that's a
vague, and
red
it was
flag
just
right there.
starting. And when they know in their heart that something's wrong, but they're
Yep.
afraid to tell their family, it's nice to have someone that has medical background too, that can really, search it out and ask the right questions. And then I go again to the specialists and ask their opinion support, and they got in immediately the next day. That was in the afternoon. We had them in to see the doctor. and then the tests were ordered.
Oh boy. So you've talked about some of the barriers that cancer patients face. Finances being one of the big ones. I mean, how much does, maybe Sabrina, you could answer this, how much does cancer treatment cost? How much do cancer drugs cost?
Actually, it really depends upon the treatment and the regimen. So, there's this very, very broad-based answer to that, and the insurer and everything else. But if we take, and we were actually just looking at these, there's this big controversy right now with a drug called Provenge for prostate cancer. So it's an immunotherapy called Provenge. It's a very, very interesting drug. It confers about an average of 4 months extended survival on individuals. It's $93,000 total. And when you look at a drug and you say, wow, $93,000, 3 infusions, $93,000, it really leads people into that,
wow,
whoa, $93,000. But people also don't realize you could take a breast cancer patient who expresses a genetic phenotype called HER2/neu, and we put them on a drug therapy for a year, and that drug therapy for a year and all of the related issues with that are also going to jump up there and approach that $100,000. So medicine is very interesting right now. It's the question about cost effectiveness, and it begs the question of how much value is life worth on a monthly basis. And I don't think that anybody wants to get into that, but it's expensive, and it's all based upon your insurers and your access and 100 different things. But it bankrupts people, as you said earlier. It really does, and it's our job to protect people from that, utilizing any resources that we possibly can. And we're lucky the Capital District has a lot of them.
So let's name some other barriers. Finding and joining a clinical trial.
If that's the patient's choice or the doctor's recommendation, I get them scheduled with the doctor as to the center that they want to go to, and we, send all of the paperwork, all the information that they need. We try and get the appointment scheduled as soon as possible so that they will know whether they're a candidate or not. And there's so many different exclusion criteria that it's important to get them seen as soon as possible. Another big thing is transportation. That's a major issue. When you have patients come in for radiation every day for anywhere from 5 to 7.5 weeks, depending on the type of treatment, a lot of patients have issues and problems with transportation. The American Cancer Society helps us out quite a bit with that, but they are limited too with volunteers. So you have to know what kind of insurance they have, if there's any avenues there. I've gotten so that I know the different counties, what's available, if there's senior citizens, what's available, and we try to connect them with that, because there's sometimes when families just can't do it, they have to work. And if the patient needs transportation, we try and assist with all that.
And then the social barriers are big. I remember a friend of mine was diagnosed with cancer, and honestly, I didn't know what to do. And I said, well, if I call, what if I'm waking her up? So then I didn't call. And I thought, well, she doesn't have email. I would think an email would be nice, but she didn't have email. So I didn't know what to do. And then I'm assuming, so that's part of it, but I'm also assuming that, you're on edge, you're sad, you're grieving, you're worried. How does that translate into daily life of a cancer patient?
When I meet with the patients, I look at all the different barriers. I start off with, do they have healthcare proxies? Do they have living wills? We try and assist them getting the information so they can get that set up. I look at whether there's barriers with communication. Is there literacy problems? How much do they understand? How much do they want to understand? You have to know the level. Some patients don't want to know anything. Some want to read everything. And some you have to guide against going on the internet because they read stuff. We give them sites that are good for them, not...
Don't just use Google.
Yes. We'll send them to the National Cancer Institute too. The NCCN have great guidelines for patients to look at. They just have so many questions, but you have to understand every person's different. Some people want to know and some don't, and same with their families. So that's where you kind of get to know them all, and they'll confide with you as to their support systems. And then if they need more support, we can send them for assistance. We can recommend different areas for psychologists. We have our own crisis center that they can be seen if there's issues.
Now, do the HIPAA laws sometimes get in your way if they haven't signed a release saying that you can speak to someone?
I usually make sure I have a healthcare proxy signed. I stress that with everyone. I have my own kids when they were 18, 19 have one, because you can't access, even your spouse without one. Really, the doctors don't have to talk to you or anybody else.
It's affecting some of the local nonprofits, however. So years ago, 7 years ago, we would call the American Cancer Society and we would say, I have, Mrs. Jones Smith sitting here and Mrs. Jones Smith needs, could you reach out to her? We can't do that anymore. Leukemia Lymphoma Society, one of the premier, organizations that exist to take care of patients, great stewards of your money. When we want to have patients, what we have to do now is we actually have to fill out a piece of paper and have the patient sign it, and then we fax it over to those organizations. Because again, somebody's sitting there, there's just so much information and so much to do, and it's not enough to just give out a pamphlet and to say, oh, here, this exists, have fun looking through it. We're really becoming more proactive to say, listen, the Leukemia Lymphoma Society exists. It helps with co-pays. It helps with reimbursement. There's support groups.
Yeah.
But would you like them to contact you? And when they say yes, you just have them sign. That's much different than putting the burden of responsibility on somebody who's already overwhelmed to say, use a pamphlet, call the number. And again, they may not even know. They know that they need, but they don't know what they need.
But I also love the idea of the information that is also written down, because
Exactly.
what percentage do you really hear and absorb and comprehend? What can you actually remember the day after that you've been told that you have a cancer diagnosis?
That's why a lot
So-
of times when I call a patient a couple days after they've met with the oncologist to see where they're at, see if they have questions, find out what they perceive they were told, because it can only take so much information in.
I actually had a person come in the library saying that she was getting brain surgery and she had some questions about the procedure, and she didn't want to bother the doctor because, he's busy, and she just wanted to look it up. Oh my God. You need to call your doctor. I mean, I can give you this book and it'll explain some things, but you need to call your doctor.
Exactly.
Sabrina, can you explain how the Patient Navigator program is funded?
Yes, the Navigator program is actually completely philanthropically funded. So when we decided to institute the concept of navigation, at that time, Newman's own foundation had provided us with a $25,000 grant to basically kick off the concept of navigation, with the understanding that we would go out and we would find more philanthropic donors. And we did. We went out into the community. We have a wonderful community support group. Individual donors. E. Stewart Jones is one of those people who rises to the to the top to help fund navigation. Other individuals, and the beautiful thing about navigation, not only now being able to show some quality outcomes, which have some measurements behind them, the patient satisfaction that patients need and they want. I think the thing that impressed me the most about Northeast Health is there's a number of donors to the Patient Navigation Fund. Our Samaritan Hospital Auxiliary came together to make a commitment to the fund. Individuals, our CEO, Norman Dasher, contributed to the fund. A gentleman who works in finance, Dan Kilmartin, contributed to the fund. Sylvia Edmonds, Larry Barnett. It was so amazing to see that donor list, and it kind of gave me chills to look through that and to say, these are our own folks who work with us, who believe. And they helped us put this program into place, and here we are, about 3 years later, and we have what everybody wants. The world wants data and outcomes. We knew it was right. Yeah. We knew it was right from day one, and it's beautiful to see it in progress.
Wow, that's great. Okay, so follow-up contact information. Would you like to give a phone number for Northeast Health?
Yes, the Cancer Treatment Center at Samaritan Hospital is area code 518-271-3231. And that will put you in touch with any cancer services that individual needs. That will put you in touch with anything that we're doing for prevention or screening. You know, we're doing a prostate cancer screening at the end of September,
Okay.
September 26th and 27th. And it will also put you in touch with the Women's Health Center department should people need to schedule mammograms. We have 3D ultrasound, elastography for breast. We're the only people in the Capital District. And we're a breast center of excellence. That designation, again, there's very few in the Capital District. So the 271-3231 number will feed you into wherever that people need to go.
Okay, and let's just mention the website.
Yes. The website is www.nehealth.com. So N is in Nancy, ehealth.com.
Okay. Thanks for coming in, ladies.
Thanks for having
And
us.
thanks for everything you do for the community. That's
you.
great.
Thank you.
Thank you.
Thanks for watching. We hope to see you next time on Focus on Health.